So VTE, venous thromboembolism, is when you have a thrombus in the venous circulation, right? So we have our veins are irritated for some reason, and usually it's the deep veins where it's the highest risk, right? So we get deep vein thromboses, and those thromboses are uncomfortable. It causes swelling and pain and such, and redness and irritation. But that thrombus can then travel to the lungs, right? Travel to the heart. And it can also, most commonly, 80% of the time, it's going to clot off the lungs, right? Causing a PE, right? But as we'll find out that, 20% of the population has a patent foramen ovale, and that can just bypass the lungs and go straight to the brain, right? So VT prophylaxis is important to prevent strokes, also important to prevent PEs, which are both life-threatening, PE being a little bit more life-threatening. Okay, so venous insufficiency we're not going to get into. That's more of an outpatient concern, whereas patients have varicose veins and they have ulcerations and such. Can they make it to the ICU? Yeah, but it's usually the arterial insufficiency going to make the ICU much more often than a venous insufficiency would. So what's the overview and how does this work? So it's all about this triad in the middle here, right? What causes thromboses is Virchow's triad. So what does Virchow do? It is V for venous stasis, right? So we got a stasis of blood for some reason, right? When blood is static, it has nothing else to do. It's like, what are you doing? I'm not doing. You want to hook up? Yeah, let's hook up, right? So they hook up and they thrombose, right? So venous stasis is a key reason for thrombosis to occur, right? So you got a hypercoagulable state. You got, sorry, over here, venous stasis, right? So obesity puts you at risk for venous stasis, right? Because blood has to go from the extremities up to the heart. And if you have obesity and you have all this increasing pressure pushing down, it's a lot harder to bring blood from the extremities and push it back up to the heart. So that's a key risk factor. Right, so we got venous stasis from immobilization, from fractures, ICU stays, right? So being in the ICU puts you at high risk for VTEs just for venous stasis. That's why we throw SCDs on every single patient, right? There's no contraindication unless there's actual like redness and pain that's happening with that SCD machine. Okay, and then pregnancy, oral contraceptives. So pregnancy kind of put it on the obesity side. Then we're going to get into the oral contraceptive part, which is the hypercoagulable state. So we have a state at which we are procoagulant. We are able to, where our body is coagulating more than it used to, than it should. And why is that? Well, it's smoking, right? Smoking is inflammatory. And that inflammation can cause damage too, as we learned, to cause vessel injury. But also, smoking is procoagulant, and it's a chemical that stimulates coagulopathies, therefore, or procoagulant states. Therefore, that puts us at risk for getting a clot to form in the deep veins, right? Which our muscles should squeeze and bring up. But again, immobility puts us at risk, but also procoagulant states such as oral contraceptives, right? Pregnancy puts you at risk as well. A lot of the things, hormones flowing around in pregnancy are also anti-contraceptive, right? Once you already have one in the oven, you don't get two, right? So you can have them at the same time. It's like a 2 for 1, right? Like 2 holes for 1, or I don't know, one hole for 2. I don't know how that's going to work. But we have, but definitely you're not going to get one afterwards, right? So pregnancy puts you at risk. Obesity put us at risk for venous stasis and bed rest and post-op and such. Being hospitalized is just 50% of our reasons. But pregnancy and obesity, which happens with pregnancy as well, actually increases estrogen. Now we're back to square one. Now we can actually have a lot of, that's almost like an oral contraceptive, right? And those adipokines we mentioned with inflammation, those things itself stimulate coagulation to occur. Okay, there are genetic reasons for hypercoagulability, so they'd be doing all kinds of fancy tests, especially like lupus tests and procoagulant tests, to figure out if they're forming clots because of a genetic reason, right? Sepsis activates the Coag cascade. So as we mentioned all the way back with our platelets, that's one of the things besides thrombin, besides another platelet, is inflammation, right? So inflammation, well, smoking's inflammation is going to trigger it, but also just sepsis itself will trigger the Coag cascade. And sometimes it gets out of hand and it causes widespread inflammation and widespread clotting, or a disseminated clotting, if you would, right? It's causing DIC. But here we have inflammation and sepsis, which obesity is inflammation as well, forming clots. And then cancer, we didn't talk about cancer, right? 1 in 5 people, so 20%, right, will get a DVT once they get a cancer diagnosis, right? So cancer is a procoagulant state. And then what else? We did talk about, just go back to immobilization, right, being in the ICU, for instance, but also being, planes, trains, and automobiles, right? London Heathrow Airport, after transatlantic flights, is the highest risk, gets the most calls for DVTs, or PEs, I should say. People don't really complain about the DVT so much, they're going to try to walk it off. But someone with when they start to get short of breath after their trip, that's now a pulmonary embolism, right? And then endothelial damage, so just damage to the endothelial lining itself. As you pointed out, that the atheroma can form collagen and be a risk factor for platelets to form, but also just straight up exposure to collagen can do it, right? Endothelial damage itself can cause exposure to platelets and the Coag cascade, and that's going to cause a activation of the clotting cascade and activation of clots. All right, so we talked about hypercoagulability. Now we're talking about vessel wall injury of some sort. So it could be stabbing, right? They have a trauma to the area. They have surgery to the area. That's what puts them at risk for a venous thromboembolism to develop there. With age, your vessels are not as pliable, so they can break down. And then inflammation, again, rearing its ugly head, with whether it be sepsis or smoking or the like. Line placement is a common reason for DVTs to form. We have a midline or PICC line in the right arm or left upper arm, puts you at high risk for clot. Why? Because you've damaged that vessel with the introduction of that catheter. Okay, and then a previous DVT puts you at high risk for another DVT. It's like up to 30-40% of chance of getting a clot again if you had a DVT before. Okay, so all these things working together put you at risk for a DVT, and then at risk for that to embolize to the brain or to the lungs. So here we got a PICC line right there in the right upper arm. You can see that's making this extremity backing up, right? So one of our symptoms of DVT is unilateral limb swelling, right? So we got swelling greater than 3 centimeters technically, right? More edema on one side versus the other, right? When you get edema from heart failure or edema from anasarca from cirrhosis, it's not like, you know what? Right leg, let's go. Right leg, right? That's where we're going. Hydrostatic pressure, oncotic pressure, screw it, just the right leg, okay? Right? That's not how it works, right? That's bilateral, right? But when you have unilateral, that means there is something blocking the forward flow of blood back to the heart, right? So that being a clot in the way, right? That clot is non-compressible. So you see over here, we got a clot in the way, right? So normally it's compressible, but it's not going away, right? Actually, that's the artery. Here's my clot right there, making my vein not collapsible. Usually veins will disappear when under ultrasound if they're close to the surface. But we have that artery on the right, which is pulsatile, and on the left we have our vein, which is not compressing because there is a clot there, right? What else is a symptom? Well, blood is warm, so we get warmth, but also this is very, very painful. There's a lot of things going to get activated, a lot of inflammation that's going to be activated, so that's going to cause a warm extremity, but also a inflamed and painful, swollen unilateral extremity, right? So all these things can be filed into this little score right here. It's called a Wells criteria. This Wells criteria is what tells you that a DVT is likely or unlikely, right? So these are just adding all the symptoms we just talked about. They got unilateral leg swelling. They have they got tenderness. They have a previous DVT, gets you 1 point already, right? Only 2 points for you to say that, oh, you probably have a DVT, okay? And then duplex ultrasound. As we mentioned, we have a compressible vein normally. So if it's non-compressible, you got a DVT, okay? And D-dimer. So D-dimer is from clot breakdown. That clot that's formed, your body's going to try to break it down. Just like with inflammation and sepsis, that's going to cause clots to form, and your body's going to start breaking it down with anticoagulation. Okay, so when you break down a clot, though, right, clot is made. Remember, fibrinogen turned into fibrin. We get a clot and an activated platelet, and then we got a huge mesh, and all that junk was together, and now we're going to start chipping away at it and breaking it apart. And how do you break it apart? That was what TPA did, right? TPA turns plasminogen into plasmin, and plasmin converts fibrin into its degradation products, or its FDPs. And we also call that D-dimer. So D-dimer will rise with any kind of clot formation. D-dimer will also rise with any kind of inflammation, as we mentioned, right? Inflammation causes clots, and inflammation also breaks down clots, right? So that whole process is not, a D-dimer level is not accurate if someone also has a infection happening. But if someone doesn't have a fever, chest X-ray that's bad, a procalcitonin that's negative, well, that's not a bacterial infection, not an infection. That's someone that's negative for infection, but they have this leg that's swollen, they have this painful extremity, and they have a D-dimer that's positive. We can trust that D-dimer. So D-dimer has false positives of inflammation or sepsis. Otherwise, it's a good test to run on someone that has nothing else going on with an extremity that's super, super sus. So the coag cascade comes again, rears its ugly head again. So we talked about platelets a lot. Now we're going to talk about the other half of the problem, right? So we had this platelet aggregation, which was part of the problem. The platelets actually activate the intrinsic pathway over here, and they're part of the problem. All right. So if we stop platelets with antiplatelet drugs, maybe we can stop the coag cascade. But now we're going to focus on the coag cascade because that's what's happened with DVTs. We're forming clots not because of narrowing from like atheromas rupturing and such, where the clotting cascade is being activated from all that Virchow's triad from inflammation or what have you, right? So we have two ways to activate the coag cascade. We have the intrinsic pathway and the extrinsic pathway. So this intrinsic pathway is stimulated by, call it GIN, so GIN in. All right, the intrinsic pathway is from collagen activation. Why would collagen be activated? From chronic inflammation, from damage from surgery, from a PICC line or midline. All this inflammation is revealing collagen, right? That collagen activates my platelets, but also it activates my clotting cascade, specifically the intrinsic pathway, right? In DVTs, you got pooled blood, you got more platelets, more factors, you got more coagulation. It's going to happen because we have all this tissue factor and collagen that's being exposed to the patient, right? I got ahead of myself. So we're talking about the intrinsic pathway here, the collagen, but also we got more tissue factors that start getting released from the endothelium, right? So the collagen gets exposed, but also little tissue factors get exposed as well. But they activate different parts of the pathway. Tissue factors on the extrinsic part, and the intrinsic part is just from the collagen itself or from platelets, right? So platelets itself will also activate that intrinsic pathway. So again, this was identified by a hematologist, and the hematologist had a death wish of Roman numerals, right, on every student hereafter. So he said, you know what, I'm going to label the coag cascade. We're not going to name anything useful. The previous guy labeled it thrombin over here, right? Thrombin, prothrombin to thrombin. That makes sense, right? Prothrombin is the precursor to thrombin. And then this guy came around and said, no, we're calling that factor 2. Get out of here, right? We're not calling that thrombin anymore. And then what about fibrinogen to fibrin? No, we're calling that factor 1. So there's 12 factors? Yes, all except 13. It's like, what? What are we doing? Or I think factor with another factor missing as well. So it's like, what are you doing here, right? So either way, we have this coag cascade eventually is going to end up with factor 10A, right? Or factor 10. 10 is that critical juncture between the intrinsic pathways, so it's a good target for anticoagulants, right? If we can stop it right here in the middle at 10A, then perfect. We're going to stop prothrombin to turn to thrombin. We're going to stop fibrinogen to turn to fibrin, and we're going to stop that mesh that's needed for the clot to be activated, and also thrombin stimulated platelets to be activated too. So that's a key piece. Right before thrombin's made, before prothrombin is turned to the thrombin, let's get a 10A inhibitor, for instance, right? So direct 10A inhibitors have 10A in the name, rivaroxaban, apixaban. Those guys are going to stop this coag cascade from getting out of hand, right? So this intrinsic pathway right here, it used to make no sense. I was like, how the heck am I going to remember this? And then this movie came out, so TENET came out, and then that solved all the problems. That was the mnemonic right there. So we know that 10A is the end, so that's that T there, right? And then it goes numerically backwards. So it's 12, 11, 9, 8, 10, right? So TENET, and where do you watch TENET? You might watch it outside, but it's usually watched inside. So this is the intrinsic pathway is TENET, right? Everything else is going to be the extrinsic pathway. So factor 8 and factor 7, and also factor the tissue factor. Those are my extrinsic pathways. Okay, so those are the two pathways that are involved. And then how do you get a clot? You have to have platelets that are functional, that don't have aspirin on board, that don't have low platelets. Then yes, you'll get a clot, right? Clotting factors are made from the liver, so you have to have all these are all different clotting factors, right? Except for von Willebrand's factor, which comes from the tissues. Okay, and then calcium. Calcium is extremely important for the coag cascade, right? Calcium is involved at many, many steps. So if we don't have calcium, it's not only these steps, there's more steps calcium is involved in, we don't get a clot. So you need those three things working in concert to be able to get a coag cascade and to be able to get a clot to form, right? So that's the idea behind the coag cascade.
I can't believe it. I've learned the coagulation cascade 15 times, and I forgot it 16. I can't get you to code me one.
So the hematologist is smiling somewhere.